Okay, everybody, we're going to get started. It's my pleasure today to welcome Dr. Rebecca Mathew to present her work in our Monday research rounds. We are going to be recording for anybody, there's no one online, but we're going to be recording. So if you missed this or you hear somebody else who needs, who missed the presentation today, they're welcome to join the recording afterwards. So Dr. Rebecca Mathew is a cardiologist here in the critical care division in cardiology. She is also an assistant professor in the Faculty of Medicine at the University of Ottawa. She graduated from U of T in 2008 with her Bachelor's of Science in Neuroscience. Oh, you're a neuro. Okay, all right, makes some maybe making some sense here. She earned her medical degree from the Northern Ontario School of Medicine in 2012, and then her residency in internal medicine at McMaster, and then she completed a fellowship in adult cardiology here at the Heart Institute in 2019. She then pursued another fellowship in critical care, also here at the University of Ottawa, and graduating in 2021. Where she then joined the Division of Cardiology. Her clinical and research interests are in cardiac critical care, particularly treatment strategies for cardiogenic shock and the long-term management and the prognosis of these survivors of critical illness in cardiology. She is also a passionate educator, and resident education in critical care is also among Rebecca's academic interests. So we're very excited to have Rebecca join us today to talk about cardiogenic shock, where we've been and where we are going. Yeah, and we don't know how to follow instructions, apparently.
Okay, thanks. All right, thank you. And thank you so much for the invitation. It's obviously a pleasure to be here. I think anyone who knows me knows that there are very few things in the world outside of my family that I love more than cardiogenic shock. This is probably a topic we could spend 8 hours and not cover everything. So it'll be a little bit of a whirlwind. So just bear with me. I think it's important, like so many things in medicine, in order to determine the direction that we're moving forward. I think it's really helpful to know where we have come from, and that can really inform the decisions that we sort of take moving forward. So this is a bit of a brief outline. And so, you know, I think like so many things as I've now sort of entered staff life and I'm entering into my 6th year, I've realized more and more there's like the art of cardiology that we practice. And then there's so much of it is the art and sort of really integrating those two things at the bedside. And I don't know if anyone has seen these in Mexico, these beautiful tiles. And I think they really speak to like the anatomical organ, but also the passion and enthusiasm and like vibrancy that we can bring to cardiogenic shock. So I just wanted to highlight that, obviously, with everything going on currently. So let's start with fundamentals. So what is cardiogenic shock? I think in its simplest form, the best way to think of it is a state of shock due to primary cardiac dysfunction, leading to clinical and biochemical evidence of hyperperfusion. And so although there has been a renewed interest in this shock state, it is still sort of runs in parallel with unacceptably high morbidity and mortality. So we see a mortality rate of these patients anywhere between 35 and 50%. So can you imagine working in an ICU and knowing that 1 in 3, you know, one in 2 of your patients is going to die before they leave the hospital? This is what we're contending with as clinicians and researchers. I think it's important to understand the magnitude of the problem so we can be renewed to sort of study this with a lot of enthusiasm. So I want to introduce you to Dr. Jung. I think many of you probably know him. So Richard was an MD PhD candidate with Dr. Hibbert's lab, and he's now one of our outstanding C1 residents in the Adult Cardiology Fellowship Program. And so as clinicians, I think we can all appreciate that we're required to integrate patient hemodynamic and biochemical factors in order to guide the interventions and therapies we suggest to our patients, but also inform decisions around prognosis. And so, you know, the conversations we have with patients are really important, and the more information we have when we're entering them, I think the better job we do with our patients and their loved ones in terms of navigating this journey of cardiac critical care. And so adjustment for prognostic covariates is being increasingly used in research, and that includes in RCTs. So Richard undertook a systematic review and meta-analysis to look at prognostic factors that were associated for short-term mortality and cardiogenic shocks. This was in hospital up to 30 days. He looked at a total of 160 studies, and this included almost 2.5 million patients, just to give you context in terms of how many people were included in this review. And he found a median mortality of 41.4%, which is sort of reflected, which is reflected in the literature that we know to date. And the thing I want to highlight here is hopefully you can appreciate the significant drop in mortality that we saw in the early 2000s. This is actually reflected with the publication of the SHOCK trial, which essentially showed mortality reduction in early revascularization for AMI, so acute myocardial infarction associated cardiogenic shock. But if you can see, the mortality rate really hasn't taken another steep downflow since that time. And that's because for 20 years, we have been studying cardiogenic shock. And up until 2024, we had no other new intervention that changed mortality, which is kind of wild. Like, we're all in the cardiovascular sciences, right? It's our jam to fix people. Like, this is what we do in cardiology. And so to me, it's always, fascinating that we studied things for 22, 23, 24 years, and we haven't moved the needle until danger shock, which we'll talk about in a little bit. And so Richard looked at this in a bit more detail, and he wanted to silo these prognostic factors. So look at patient factors, presentation factors, and then procedural factors. So under patient factors, things I think that make sense clinically: older age, a history of malignancy, prior peripheral arterial disease, things like presentation factors, so presenting with cardiac arrest, either out of hospital or in hospital, having a low EF or a left main as your culprit artery, and the procedural factors like a suboptimal TIMI flow after PCI, delayed revascularization, or needing more organ support, so higher rates of mechanical ventilation or renal replacement therapy. And I would encourage you not to worry too much about the tables and the specific factors, but I think the takeaway point here is actually that prognosis and prognostication in the management of cardiogenic shock is dynamic. It's fluid. It's not like patients come in and they're static at that point in time and we can make an assessment about prognosis in hospital. This is something that changes over the course of hospitalization, and we need to constantly bring in these new variables in our discussions with patients and their loved ones to talk about what resources make sense, what resources don't make sense, and in a public healthcare system with human and financial resource limitations, where do we put those resources in caring for these patients? I think that's really the takeaway from this side of Richard's work. Something really interesting that's also happened over the last 10 to 15 years in cardiogenic shock is we've started to move away from this concept like it is this homogenous one ball of a disease state. So someone comes in, their heart pump is weak, they have cardiogenic shock, and all the X's get Y's. We've really started to say this is a much more heterogeneous patient population that we appreciate, and how can we silo these patients into different subcategories and categories, and as a consequence of that, really try to tailor therapeutic interventions to these different cohorts of patients. And so for years and years, people have tried to classify cardiogenic shock. So I remember when I was training, we used Intermax. I feel like we don't even really talk about Intermax anymore. We have an advanced heart failure person here who's, I think, saying we don't really talk about Intermax anymore. That's what we had when I was training. We have risk scores that have come out of clinical trials. So we see that in the IPV Shock 2 risk score. We see things like the Cardiogenic Shock Working Group classification. In 2019, the SKY classification was published, which completely changed the language from a research and clinical way in terms of how we speak about these patients. And then more recently, we've had updates of the SKY classification in terms of, how do we separate out these different cohorts of patients? How does that inform prognosis, and how does that inform therapeutic interventions? So this is something that's sort of happening in parallel with investigations for treatment targets. But the question I would ask all of you is mechanical circulatory support bad? Is it good or is it bad? Well, it's good for some patients and it's bad for others, right? Are inotropes good or bad? I'm probably the wrong person to ask that, if anyone knows my research, but they're good for some patients and they're not so good for others. Same thing for vasopressors. So how do we identify what patients are going to respond to what therapy? And that's where this concept of phenotyping and subphenotyping has really taken off in cardiogenic shock. And so the early work that was initially done on this topic was by Elric Zweck. And so just to inspire all the trainees out there, he was actually a fellow when he published this article and came up with this idea. So I always find now is I'm kind of transitioning into my mid-career staff life, and the best questions and the most inspiring conversations are always the ones I have with our fellows and our trainees, because they have zero problem questioning us in the unit. We'll say something and they'll be like, I strongly disagree, and here's the most recent data. So for everyone who's training, this is where you should live. Question your seniors, question your attendings, questions your supervisors, because this is what makes us better. So Elric is a phenomenal future clinician scientist in the cardiovascular sciences. And he basically used a machine learning model in order to identify phenotypes of patients that were presenting with cardiogenic shock. He said there must be some heterogeneity in this cohort. How do I figure this out? Let me use a machine learning model. And so he initially studied these phenotypes or tried to identify these phenotypes in an acute myocardial infarction cohort of cardiogenic shock. And then he validated that in a heart failure cardiogenic shock cohort. And he basically identified 3 different phenotypes, and hopefully you can see them here. So he showed the non-congested phenotype. Those patients tended to be a little bit younger, fewer comorbidities, lower heart rate, higher blood pressure, less organ dysfunction. Then he identified the cardiorenal phenotype. These patients were older, more comorbidities, higher filling pressures, lower eGFR, so kind of representing that renal impairment phenotype. And then he identified the cardiometabolic phenotype. These patients had markedly worsened end organ dysfunction, so higher creatinine, higher lactate, higher liver enzymes. And so what he actually showed are these phenotypes were clearly associated with a progressive increase in in-hospital mortality. So non-congested patients did better than cardiorenal, cardiorenal patients did better than cardiometabolic. So again, it seems really simple when you go back and read the literature, but this was actually groundbreaking at the time that it was published. It was one of the first studies that really said, hey, these patients aren't one homogeneous blob. Let's try to kind of separate these patients out. Now, what they didn't do was look at response to therapy, but this is kind of the first foray into subphenotyping. Now let's take that one step forward and let's go even more down biochemical phenotyping. And I know Dr. Rayner and I have kind of talked about biobanking and sort of the importance of this. And I know that's something the building really believes in. And so this is essentially work that was done by a colleague of Dr. Parlow and I. We work together and do research, Sabri Susi, who's in Toronto. And so what he basically did is he said, I want to look at very specific biochemical markers, and I want to do something called latent class analysis, which is essentially the identification of categories and subcategories that are previously unestablished or unidentified in a heterogeneous patient population. So a much more kind of nuanced version of what Zweck did in the previous slide. And so we basically looked at all of these markers in an observational prospective cohort. So we used the Card Shock and the Frog ICU cohorts, which are just registries from before if you're not aware of them. And he identified these 4 specific phenotypes: the adaptive, the non-inflammatory, the cardiopathic, and then the inflammatory. Then he took those biochemical markers and those phenotypes and he prospectively looked at 3 RCTs. One of those RCTs was our DOREMI 1 cohort. So we actually had those lab samples. Poor Dr. Jung had to like unfreeze them, freeze them, pipette them out, and ship all of that to Paris, France. So nobody go ask Richard about that. I'm sure he has some degree of trauma for having to do that for 6 months. But we shipped all of that stuff to Paris, and we had our colleagues in Paris basically add this to their data set. Also in Optima CC and then in Culprit Shock, and he very clearly showed that 28-day mortality was incrementally stepped up as you progress through these 4 phenotypes. So the question you might ask is like, okay, well, what did he look at for these phenotypes? So I'm going to show you. Here are the variables that he used. And they're not terribly complicated. And I think as clinicians at the bedside, we do look at these values in our patients. With a cardiogenic shock, we look at the troponin, we look at the CRP, we look at the platelets, we look at what the white blood cell count. Like these are things we use clinically. And so they basically showed that the adaptive phenotype had lower levels of circulating markers of end organ dysfunction. The non-inflammatory phenotype had a very low CRP. The cardiopathic phenotype had high levels of cardiac biomarkers. And then the inflammatory phenotype had much higher markers in terms of end organ dysfunction, as well as CRP. Now, how does this relate to therapeutic intervention? That is obviously the holy grail of cardiogenic shock work, and we're not there yet. So I would argue that this is interesting, hypothesis generating, but it's really kind of exploratory and nothing more than that at this point in time. But I imagine in a world, I hope I'm retired by the time this happens, but I imagine there's going to be a point of care machine in a cardiac ICU at a quaternary care center. You're going to come into that unit sick as could be with cardiogenic shock. We're going to take a vial of blood, we're going to phenotype you, and then we're going to know what customized therapies, drug and devices, because we're cardiologists, we love our toys, and we're going to know what makes sense for you. And so I think we're at the precipice of where this is coming, but what an exciting time to be a cardiovascular clinician and scientist, because I think it's really up to us to figure out how we're going to map this forward, because this work is being done, and at all the major conferences, this is what we're talking about, phenotyping and subphenotyping. So I really wanted to just highlight Sabri's work, because I think I really do think that this is kind of where we're going and where the field is evolving for customized medicine. Now, that is the pipe dream. That's something I hope happens in 15 or 20 years, hopefully earlier. It is important to really highlight that even the most simplest of questions haven't been answered in cardiogenic shock. So for all the clinicians out there, what's the first thing that our nurses ask us when we bring in a shock patient? What do you want to target? Map, right? Isn't that always the question? I feel like I'm like putting a swan in and I'm being asked about the map. And we oftentimes say, okay, 65, because that's the number that we use, because for the last 25 years, that's the number that we used. But even map targets and blood pressure targets aren't established in cardiogenic shock. So this is actually the NORSHOC study, which is ongoing right now. They've been recruiting for quite some time, but they're basically looking at, standard map target of 65 against a lower map target, so using 55 in patients with AMI-associated cardiogenic shock. Their primary outcome is all-cause mortality and renal replacement therapy, the idea being that you might be able to salvage the kidneys just by sparing levo-fed dosing. So again, a very simple question, something that we would think has probably been answered in cardiogenic shock, and it hasn't at all. A step up from that is the use of Swan-Ganz catheters. So here in Ottawa, we are a high Swan use center. We like our Swans. We enjoy them. Laura, our nurse educator, is here. She knows how much the fellows and the staff enjoy using Swans. Not every center is like that. And it's important to realize, the very privileged place that we work in academia, that we actually have access to Swans. So do Swans make a difference? If you talk to cardiac intensivists, we will almost uniformly tell you, of course they do. They allow us to phenotype the patients. They allow us to titrate therapy. They allow us to decongest when they need diuretics or give them higher vasopressors when their mixed venous is low. But that actually hasn't been studied in a robust cardiogenic shock patient population. So PACS is a multi-center RCT. It's out of the US, and they're looking at heart failure associated cardiogenic shock. So these are not your MI patients. These are your sort of decompensated heart failure patients. And they're looking at an early invasive hemodynamic assessment, so full Swan-Ganz numbers between the first 6 hours, and then delayed management, so Swan greater than 48 hours or no Swan at all, just our hands and our eyes and our stethoscope and our usual biochemical markers. Their primary endpoint is all-cause in-hospital death. So I'm hopeful that this will get published maybe next year. That's kind of the gossip in the cardiogenic shock world, but we'll see when this comes out. And I think it has the potential to really change how we manage these heart failure patients if we actually have RCT data showing that there's a benefit. So again, two things that I think we would think just kind of anecdotally are very easy. Of course, I know the map, of course, the Swan helps, but just to highlight that we really don't have a lot of robust literature looking at even these simple interventions. The last thing I wanted to talk about in this section is this concept of inflammation. And so I can see Dr. Boxer in the back, who can probably speak much more to this than I can, just because this is an area of interest in him. But in the last kind of 5 or 10 years, there's been this growing movement in cardiogenic shock management about the inflammatory milieu. And so there's an editorial that I read last year where I love, they sort of talk about acute myocardial infarction as a tsunami. And so we're very focused on getting the wire down, opening the stent, getting the antiplatelets on board, and fixing the acute plaque rupture. But how do you manage a tsunami? Are we really able to beat back the waves in the ocean? That's hard, right? The tsunami's coming at you, the waves are there. You can do what you can, but it's really hard to deal with that. Maybe the more interesting therapeutic target is actually what drives the tsunami. The tsunami is really driven by earthquakes in the ocean. So maybe if we can quell the ocean and settle the earthquakes, maybe the tsunami doesn't happen at all. And so maybe over the last 20, 30 years, our therapeutic targets have been so downstream that it's only now that we're starting to think, let me look upstream and see what else I can change and what else I can intervene on. And so this is where this concept of like, is inflammation a trigger? Is it a consequence of cardiogenic shock? Is it both? Is it sort of yin and yang and kind of, a trigger that then perpetuates circulatory decline? It's really hard to know. And I think it's an area of profound interest right now in CS management. And so there's a couple smaller studies that I just wanted to highlight. So Jake Genser's group out of Mayo in 2020 looked at almost 9,000 patients in their database who had 2 or more of the usual SIRS criteria in cardiogenic shock, so SCI A to D. And they showed that those patients had much higher illness severity, organ failure, and actually 30-day or in-hospital mortality. Montero and colleagues more recently in 2022 looked at 63 patients who had STEMI-associated cardiogenic shock, and they very clearly showed that as you progressed from KILLIP 1 to KILLIP 4, you had a parallel increase in your inflammatory gradient. And then Detling and colleagues in 2023 looked at about 110 patients who had cardiogenic shock and showed an 8% increase in 30-day mortality for every increase in CRP by 50. So again, like, are these therapeutic targets? Are they markers of systemic illness? Do they represent something in between? It's a bit TBD at this point in time, but I think it's really important to start thinking about what's happening upstream as opposed to just being very reactive. I think this is the opportunity to be a bit more proactive in how we manage these cardiogenic shock patients. So this is work by Kunkel and colleagues back in 2023, and they wanted to look at the correlation between inflammatory biomarkers and 30-day mortality in patients with AMI-associated cardiogenic shock. So they actually had a large cohort, it's about 1,700 patients, and a very sick cohort. Their 30-day mortality was actually upwards of 50%, comparatively to like the usual numbers are kind of 40 to 45%. They showed that the median white blood cell count peaked in the first 24 hours, but the median CRP actually peaked a little bit later at 48 to 72 hours. And they very clearly showed that the highest inflammatory response was among those who had worsened EF, those who had higher lactate levels, and those who had progressed to more severe SCI shock stages, so D and E. And so the 30-day mortality was highest, as you can anticipate, in the upper CRP and WBC quartiles. So again, I think it raises that question where, like, is it cause? Is it consequence? Is it both? I must admit, I don't know, but I think that this, when you sort of talk to people who are doing research in cardiogenic shock, there's so much interest in this inflammatory milieu and what are the ways that we can address it. And I think we think about this in the context of mechanical circulatory support. We know that that can drive an inflammatory gradient and milieu for our patients. So how do we attenuate that in patients that need to go on to MCS? I think is also kind of an interesting clinical question that we don't necessarily have the answer to. One trial that I think will be particularly interesting when it's published, and it's done recruiting, so everyone's anxiously, impatiently waiting, is Doberman. And so Doberman's a study that's been done out of Denmark, and it's a 2x2 looking at patients presenting with AMI at risk of developing cardiogenic shock. And so this, I think, is important. These patients don't have CS. They're identified as being at high risk of developing CS based off something from the Orbi score, which I'm not going to get into today, but it's a validated score for the development of cardiogenic shock in acute MI. And so the patients are randomized in a 2x2 to dobutamine. The idea of dobutamine being it has a positive chronotropic effect, a positive inotropic effect, and it has some systemic vasodilatation. It may actually improve cardiac output in these patients with low cardiac output, and tocilizumab, an IL-6 inhibitor, with some kind of early data showing maybe reduced infarct size and myocardial salvage in AMI. Now, their primary outcome, and our internal capital lab group has had a bone to pick about the primary outcome, is NT-proBNP levels. The idea that the investigators said is that it's a preclinical proxy to the development of cardiogenic shock. We can pontificate on if we agree or disagree with that primary. I think for anyone who's doing trials, we all understand pragmatism is a big part of what's possible and what isn't and ends. But Doberman has finished recruiting and hopefully will be published this year at some point. So I know Dr. Parlos is equally excited for me. We know the group, and I think it'll be really exciting to kind of see Doberman out. So I'm going to transition in terms of kind of where we were and some interesting therapeutic targets a little bit more to our lab here in Ottawa. And the thing I think that's really important to highlight is there are giant gaping holes in our knowledge in the management of cardiogenic shock, which I think we don't necessarily appreciate or account for. And so what we don't necessarily see in the guidelines is a reflection of this uncertainty in the recommendations. And so I think we really do need to put that into the guidelines. I think it's really helpful clinicians to understand the limitations of the current data, and more importantly, create a roadmap for future data and for future studies that we're going to undertake. And so the most complex analyses of the largest data set cannot overcome the power of randomizations. So while it is very normal to be uncomfortable in doing these high risk, high reward trials in terms of studying patients with cardiogenic shock, it is absolutely necessary to move the field forward in a meaningful way. And so I personally believe that funding should be linked to asking these important questions. Just because it's difficult, just because it's uncomfortable, doesn't mean it's not ethically and scientifically justified. Those two concepts are not mutually inclusive. They're very separate. And I think we're starting to see that reflected in funding patterns, but it needs to be reflected more strongly. So the other thing that we talk about a lot in cardiogenic shock is sort of explanatory trials versus pragmatic trials. And so, I think it really comes down to what the question is you're asking. When we talk about explanatory trials, the question we're actually asking is there a true difference between these two interventions? What we're asking with pragmatic trials is, of these two interventions, which should we use? And although the nomenclature sounds very similar, I think it's really important to highlight that difference. Explanatory trials are very much focused on understanding. We want the perfect idealized patient population. We want very strict adherence to our protocols, and we have a highly controlled comparator. Versus pragmatic trials, we're really focused on, I need to make a decision at the bedside, and what am I going to do for my patient? The trials designs tend to be much more simplistic, and we're really trying to replicate real world care when we undertake pragmatic trial designs, because the focus is making a decision at the bedside for the patient in front of you. Our research group has very intentionally chose to focus our profile into pragmatic trial design. So that's where kind of we live, is on the far end of this spectrum. I think because it's weekly research rounds, I also just wanted to highlight the importance of trainees and bringing in multiple people into your research program. I think that we're so great at it here in the building, but we can always be better at it. There's pros and cons to everything in life. I think there's so many more pros to involving trainees in research than any cons. They are so much more motivated and highly skilled than I think we give our trainees credit for, certainly with our adult cardiology fellows. I think there's also this concept that our mentors have tried to instill in us, which is you're training your future colleagues. You're training the next generation of clinician investigators and clinician scientists. So if you can impart on them this culture of collaboration, coming together, undertaking pragmatic trials, that's like kind of that, it sounds like a Ponzi scheme, but it's not, because that has a very negative connotation. But it's a bit like that pyramid where you're sort of building out this next generation of people to work with. And at least in our building, our fellows allow 24/7 access to patients who are recruitable. So this is an amazing way to bolster your numbers and get these patients into trials. Of course, there's downsides. Trainees are not coming usually with full PhDs and research portfolios in hand. Richard's a bit of an exception. So they do require more support for methodology, for stats in terms of developing trial design. There's a lot to be said for availability. So I know myself, when I was a trainee and undertaking my first clinical trial, I was probably texting my mentor 5 to 7 times a day. And like a good mentor, he picked up his cell phone and he texted back. But I can imagine now being a mentor getting texted 5 to 7 days, it's exhausting. And so you need to be willing to put that time in for your trainees and know that you will get that back in multifold. But I think, like so many things in medicine, availability is number one, being around for your trainees and being willing to take those phone calls, but certainly it's more work. And I think the other very important thing to highlight is trainees deserve to be given recognition for their work. And so this is where authorship becomes something that we talk a lot about in our lab, but they deserve authorship. They deserve first authorship. And I think that's a reflection of the work that they put into doing these studies. I couldn't come and do a presentation on research and the lab without talking about do re mi. I hope people know Sound of Music. I was doing the slides on the weekend, and so I was pulling this up out of Google, and my daughter made me play the actual do re mi song 7 times. And I realized my next idea for do re mi 3 does not match with the song. And so I keep trying to tell myself what device or drug can I study to finish out that song? Because I think that's a perfect punctuation mark on my career. We're probably going to call it do re mi 3, unfortunately, because we're not clever enough yet. So this is kind of the OG, the original thing that Capital Lab is known for. So it was our first brush into ICU level cardiogenic shock trial work. So this was a double-blind RCT of milrinone versus dobutamine. We looked at 192 patients with SCI BTE cardiogenic shock. Many lessons learned from that trial. We opted at that time to stratify randomization by LV/BIV versus predominantly RV dysfunction. We won't do that again. That was a hard-learned lesson, but this is the nature of doing trial work. And we chose a composite primary endpoint, which you can see here, which I'm not going to get into further. In terms of our primary and secondary outcomes, the short part of it is there's no difference. So we looked at our composite, individuals of our composite, multiple secondaries, and there was no difference. And then we had very specific pre-specified subgroups, and we found no divergent results, including age and the need for vasopressors at the time of randomization. We also used a repeated mixed methods model to look at continuous variables. So things like the vasoactive inotrope score, which for those of you, if you're unaware, is essentially like a numerical summation of all your pharmacologic support. So it's widely used in cardio or in shock research, but also in cardiogenic shock research. Urine output, creatinine, and lactate. And again, everything was very consistent. So we found no difference. Whoops. Sorry. And then in terms of limitations and conclusions, I think like all trials, it's important to acknowledge this. We only looked at in-hospital outcomes. I always highlight to people that we were actually just cardiology fellows when we were doing this trial. So we were learning ourselves kind of about trial methodology. We didn't have the infrastructure to look at outpatient or sort of more long-term outcomes. But certainly, like we saw in the shock trial, there may be differences that you see beyond the index hospitalization. Our trial was also very intentionally designed to be pragmatic. We really wanted to replicate clinical practice at that point in time. Our first patient was recruited in 2017 for this study. And so we defined shock clinically as opposed to hemodynamically. Our study did have a mortality, oh, sorry, I think it's on a timer. Our study did have a mortality rate of 40%, which is what you see in the literature to date. So we do feel like we recruited the patients that we intended to recruit. Our power calculation was based on a relatively large treatment effect for a combined outcome. So certainly it wasn't powered to look at smaller differences. And so ultimately, as we had suspected clinically before we did the study, selection of inotropes could really be based on your comfort as a physician, cost, and the patient's individual response to therapy. And I think like so many things in medicine, just because we do it and we've done it doesn't mean it's correct. And so this is why even these fundamental components of our clinical practice do need to be studied in a methodologically robust manner so we actually know what we're dealing with. We looked at a number of sub-studies, and so I think, we definitely took a card from the book of Dr. Thiel in Germany in terms of taking one trial and just sub-analyzing it to a long place from here in terms of all the sub-studies. And so Dr. DeSanto, he was here, he trained, he did his MD, PhD here. He's now at the Mayo Clinic in Rochester, looked at the impact of baseline beta blocker use on inotropic response and outcomes. And so very interesting, we actually found that oral beta blocker therapy in the 24 hours preceding randomization was actually protective from cardiac arrest and death in that early resuscitative period, so the first 48 hours. We also showed that beta blocker therapy was not predictive of this reduced or attenuated response to dobutamine therapy, as has been long cited in the literature if you talk to clinicians. And so it's interesting, when we were sort of doing the sub-study for this as a group, we met and we said, wouldn't it be interesting if beta blockers were actually a therapeutic intervention, that you could somehow modulate the arrhythmogenic risk in patients who are presenting with cardiogenic shock? Again, it is exploratory, it's interesting, it's hypothesis generating. Does anyone have the gall to actually give fresh beta blocker to a CS patient? I don't know. I'm nervous and I'm in the unit 14 weeks a year, but if anyone is willing to do that, I think that would be fascinating. But there's things that are, pragmatic, and there's things that are just not possible. But I do think it's an interesting signal that we saw in that study. Dr. Parlow's here. He's sitting in the front row. He can tell you more about this than I can. But Dr. Parlow looked at the association between MAP outcomes in that early resuscitative period. So looking at patients with a MAP higher than 70, those with a MAP lower than 70 in the first 36 hours. And he found that a higher MAP in the early resuscitative period was associated with improved outcomes and better biochemical parameters. The effect was actually independent of inotrope selection. And in lower MAP group, we saw the patients were older, they had a higher average VIS score, and they were more likely to be on vasopressors. Now, this is hard. Is this just a marker of poor prognosis, or is it a therapeutic target? We had actually talked in our group about doing a separate MAP study, but with Norshock ongoing, I think that'll be something more interesting to explore first before we sort of delve into another trial on MAP targets. But I think, again, really speaks to the uncertainty of what are the therapeutic targets in this population. And then again, just to highlight Dr. Jung again, he looked at the difference in AMI-associated cardiogenic shock versus non-AMI, which encompasses mostly heart failure, but there's other etiologies there. About a third of our patients were AMI-associated, and those patients had a higher mortality and morbidity and more likely to need end organ support, so things like dialysis and MCS. Interestingly, inotrope did not differentially impact the outcomes in AMI versus non-AMI. And I don't know if people are aware of this, but there's a lot of talk about dobutamine increasing myocardial oxygen demand, not using dobutamine in AMI-associated shock. And I think, at least there's a signal here that suggests that maybe that was a bit of an overcall. And if you actually go back and look at the studies, it was by a study by Monrad and colleagues from the 1980s. So again, understanding where you've come from is really helpful in terms of where you're going, because a lot of this, I think, is lore and dogma, which isn't necessarily rooted in evidence-based medicine and methodologically robust studies. I will move on to just briefly to talk about Capital Do Re Mi 2. So again, not a terribly creative name, but I feel like people know us for Do Re Mi, and so everything's named Do Re Mi now. So this is a multi-center RCT of a single inotrope therapy, but actually against placebo. And that's in the early resuscitation period of just SCAI C and D cardiogenic shock. What I will say, as a group, we learned so much in terms of doing Do Re Mi 1. And that's why I love that concept, which is like, failure is the stepping stone to success, because you won't know what to do different unless you've mucked it up a couple of times before and you know how to improve things. And that was something big that was helpful for Do Re Mi 2 for us. The single inotrope can last up to 12 hours versus placebo. And the reason for that is we're very focused on the initial resuscitation period. I think it's also important to remember you have to get through ethics when you do these trials. And so you really have to justify that there is a clinical question and that patients are being kept safe. And so although there is what the literature tells us, there's also what people feel comfortable with at the bedside. And so I think as clinical trialists, we're sort of obliged to find that balance in terms of what is the scientific question and what our physicians are actually comfortable with in terms of doing. We have a primary endpoint here. Again, it's a composite, all-cause in-hospital mortality, and then just markers of unsuccessful resuscitation. We actually had the benefit that our intervention arm was essentially most of Do Re Mi 1. So we were actually able to go back and look at what markers correlated with in-hospital and 30-day mortality, and that essentially informed our primary composite for Do Re Mi 2. The other thing I want to highlight is we actually got CHR funded for this in 2023. So that was super exciting for our lab. It was our first CHR as a group. Many celebrations were had with non-CHR money, with our private money. But it was very exciting as our group to sort of bring this forward and feel like we were getting recognition for some of the work that we've been doing. This is the algorithm for Do Re Mi 2. And so basically just to show you, we randomize the patient, we screen them, randomize them, they start the drug. If they don't reach an endpoint, the study drug can stop, and they can either go on to nothing or open label inotrope, so different drugs stop. If the study drug is started and they do have a primary endpoint, you can totally stop the study drug, stop the inotrope, and then go to open label inotrope. However, if the patient's endpoint is that it's felt to be continuing to improve, We've actually continued the study drug to 12 hours. That was very intentional because we want to keep the group separated for as long as possible. This also speaks to the importance of clinician assessment. Patients are more than their numbers and they're more than their ECGs. And we as the clinician can have patients that are getting better, even though the numbers may look static or potentially like one part of it is getting worse. It's holistic, right? When we care for these patients in pragmatic trials. Our most recent update is we're recruiting at 3 sites. We're looking at onboarding a 4th site, but we only have about 40 patients left. We've recruited 305 patients for a total N of 346. So we're in the tail end. We're almost there. We're hoping to be done for the end of 2026. We've had multiple DSMBs with no issues in the interim. And I just really wanted to highlight, how the fellows are woven in so deeply into terms of our trials. So they are involved in terms of writing the protocols, submitting grants, getting the REB applications done, onboarding their co-residents, and then of course deeply involved in the statistics, the manuscripts, and all the sub-studies. And I think Dr. Parlow can speak to this more than anyone. He was our poor resident champion when we rolled out DoReMi 2 and got called many, many, many times in the middle of the night to come in and help. But this is part of the process, and this is how you learn. I realize I'm probably getting close to time, so I apologize. I'll kind of whiz through the last bit. Is that okay? Okay. So I want to highlight Dr. Motazedian Puya, who most of you know. He's currently an ICU fellow wrapping up his fellowship. He also did a full cardiology fellowship here. His area of interest is actually ventricular arrhythmias and cardiogenic shock, and he's really kind of led the way at a national and North American level, actually in the last few months, about how to manage these patients. And so he talks a lot about ventricular electrical storm being sort of this triad of a vulnerable substrate, so the myocardium, some type of acute trigger, and then a degree of autonomic dysfunction that can kind of put these patients into a tailspin. And so Precedex's alpha-2 adrenergic agonism may be a targeted therapy. So the SEDATE trial, which he started from the ground up, looks at the utility of Precedex for modulating this autonomic dysfunction in ventricular storm. They have a primary outcome, which is listed here. And since May of 2024, when they started, they randomized 82 patients, which is a huge number considering that ventricular storm is not terribly common. And so some of the feedback that we were given when we were putting this protocol together is these patients don't exist. And clearly they do, at least 82 of them that have come through the unit. And so as of January of this year, SEDATE is also CHR funded. So I really just want to highlight how much work Puya has put into this study. It's really been a labor of love, and so incredibly proud of him and Dr. Ramirez as his PI on the study. This is the protocol again for SEDATE. It's a little bit more complicated, and it's actually a 72-hour study intervention period. So definitely from a CCU nursing staff perspective, this is a much larger undertaking, and it's Health Canada regulated. So there's more moving pieces to it than what we saw with DoReMi 1 and DoReMi 2. But I think as a group, this has again allowed us to sort of explore another way of doing trials and kind of add this to our portfolio. And then a quick touch on MCS. MCS, I think, has really expanded beyond what the evidence tells us works. And I think anyone who's doing clinical medicine has seen this. There's this fascination with MCS without a lot of data showing clear benefit. And there's 3 trials that people talk about most recently. So the first is Dr. Thiel's trial in 2023. He looked at 420 patients that were presenting with AMI-associated cardiogenic shock that were planned for early revasc, and upwards of 90% were for PCI as opposed to CABG. They were randomized to early ECLS versus usual medical treatment alone. They had very specific definitions for cardiogenic shock, and their primary was all-cause death at 30 days. They looked, in terms of their primary, it was actually a negative study. And so I've heard, I wasn't there, is that when Dr. Thiel actually presented ECLS shock, he very dramatically said, ECMO is dead. I don't think that's necessarily true, but I don't think this trial will ever really be replicated again. It was a very well done study, balanced baseline characteristics. 2/3 of the patients patients were STEMI, but I will say, you know, over 2/3 of the patients, about 77% of the patients actually underwent CPR. And so it's important to understand that a huge proportion of these patients were cardiac arrest patients. And so it's important to kind of take that into mind in terms of how we can apply this data to our patient cohort. And as expected, we saw higher rates of moderate to severe bleeding as well as peripheral vascular complications in the ECLS group compared to the control group. So is there a role for ECMO? Of course there is, right? We've all seen the patients where they go into ECMO, they get better, they recover, they go home. But I think the, you know, rushing, sweeping use of ECMO is probably not needed or evidence-based. So it's all about understanding the right device for the right patient at the right time, right? This is where we're going in cardiogenic shock. Dr. Moller's study, he works out of Denmark, was danger shock. 360 patients with STEMI-associated cardiogenic shock, so even more specific than AMI. They were randomized to microaxial flow pump device, so the Impella CP versus standard of care alone. Again, they had a very clear definition of cardiogenic shock. Their primary outcome was actually all-cause death, but at 6 months, so 180 days, and they had the usual secondary endpoints. And for the first time since the shock study was published by Judith Hochman and colleagues, we actually have a positive study. So again, in cardiogenic shock, we were waiting 24 years for this to happen, but we essentially showed that there was a number needed to treat for 8 for benefit of using Impella in AMI-associated cardiogenic shock compared to standard of care alone. There were very important exclusion criteria that I think are not always highlighted in this study. And so in danger shock, patients who remained comatose on presentation to the cath lab were excluded. So that's an important exclusion. And patients with overt RV failure with formal echoes being done were also excluded. So again, it's not to say that Impella is for every STEMI that comes in through the door. It's understanding who is included, who is excluded, who is the patient population that this trial was geared towards, and knowing that there's a benefit in that cohort. I think as people do more exploration and more studies, and like any good trialist, the trial should be repeated to prove the effect that we saw, that it wasn't a one-off. I think that will give us more information in terms of how we use this study moving forward. But I think with danger shock being positive, there has been a rapid increase in the use of Impella. We've seen that clinically. And then finally, the ALT-SHOCK 2 study, they looked at 101 patients with heart failure associated cardiogenic shock, randomized to early balloon pump versus standard of care. Their primary outcome was survival or bridge to heart replacement therapy, so LVAD or transplant at 2 months or 60 days. And the study was essentially negative. It was actually stopped for futility, and there were no differences in the secondary outcomes. And I think that's really in line with what we saw in IBP Shock 2 and CRISP AMI, which both looked at AMI as opposed to heart failure shock, but again, showed no difference. So although I feel, you know, very sad for the company that makes intra-aortic balloon pump, I think we're struggling to find more and more indications for this device because trials keep coming up negative. So I'll move away all of that and I'll just move into the last bit of the talk, which I think is, you know, really sort of the art of medicine. And I think medicine is the most, it's the strongest humanities, I think, of the sciences, because there's so much emotion that I think as clinicians we sort of bring to the bedside when we're caring for these patients. So this is a beautiful diagram. I love it. It's from Dr. Harridge's work in Toronto. She really focused on the ARDS patient population, but she really talks about like the patient's journey. And so we talk about patient A that come into the ICU. Patient A gets super sick and then they're sort of slowly regaining their functional recovery, but not really at where they were at their pre-admission baseline. Patient C comes in and they die. There's nothing we can do. We do everything we can, but they don't survive. And I think patient B is an interesting patient. Patient B comes in, they get super sick, and the dashed line is meant to show you what we can do to attenuate or minimize the iatrogenesis that we bring to their critical care stay. We do things to save patients' lives every single day, but remember, like everything in medicine, it does something for you, but it does something to you. do. And so we don't always remember that. We see ourselves as, I'm saving the patient's life, I'm doing what needs to be done, but there are very serious consequences to the interventions that we undertake on our patients. And so what we can do to attenuate the trauma and the complications that we call them, that will determine the trajectory. Do you follow the dashed line? Do you follow the other line? Do you ever recover in a meaningful way? And there's so much that we don't know about cardiogenic shock survivorship. So in the latter part of 2025, there was a really nice statement that was published by Hall and colleagues, where they essentially talked about cardiogenic shock survivorship. We've been talking about this in ICU for decades. So for people who work in medical surgical ICU survivorship is a huge part of what we do. There's established clinics, there's years and years of research. It's very unexplored in terms of cardiogenic shock. And so Hall and colleagues really highlighted, I apologize, it's very small, all the questions we have remaining in terms of cardiogenic shock survivorship. How do people's families deal with this new person? How do people recover their cognitive, physical, and emotional health? How do they live with permanent devices like ICD and LVADs? How do they survive post-transplant? We don't really know this, right? And they sort of also talk about how there's a lot that we know about PICS, or post-ICU syndrome, in the medical surgical cohort, and there's many, many, many question marks, which cardiogenic shock cohort. It's also important to remember that survivors of cardiogenic shock may have much more significant implications in their post-hospitalization life. So they're going home with an ICD. They're going home with an LVAD in place. They're going home and their bodies look different because of scarring from mechanical circulatory support device implantations that are in place. They're going home with the significant understanding that they have major functional limitations. They may not be able to drive. They may not be able to work. They may be left with NYHA class 3, class 4 heart failure. They may never be able to fly because of pulmonary hypertension. So these are things that are so much more long lasting than the index hospitalization, and that we really know very, very little about. Hall and colleagues also, I really like this picture because they kind of talk about this patient as they walk through the journey of their hospitalization, and they actually do give some recommendations, although none of this is just what they're recommending in the CIRC article, where they sort of talk about, like, how do we screen for post-intensive care syndrome in our cardiogenic shock survivors? How do we bring these patients into post-CICU clinics? There's been a call for these clinics at an international level to support these patients. How do we support the patient? How do we support their family? This is so much more than PICS. There's actually a concept called PICS-F, which is PICS that includes the patient's loved one's family, because we know that the whole family changes when a survivor of critical care actually makes it home. And so I think it's a really beautiful article where they sort of summarize all of this. Our research group is also incredibly interested in this as well. So we developed the Lotus CS program. This is in collaboration with our colleagues at ICES, and it's a series of studies that we've done, essentially looking at the administrative data at the Ontario level. And I just want to highlight one of my dear friends and colleagues, Dr. Fernando. I did my ICU fellowship with him, and he's really run with this. He's developed his own Lotus program for ICU, and then he's helped us with our Lotus program for cardiogenic shock. For those of you who may not know Dr. Harold Sterling, so he was one of our cardiology fellows here in Ottawa. He's finishing up his ICU fellowship in BC. He'll be coming on a staff at BC in July, and it'll be amazing to finally have a collaborator out in the West Coast who can hopefully fly us out for some better weather with some of our research presentations. And so Lee really wanted to look at long-term outcomes in AMI cardiogenic shock survivors. So he had a cohort of almost 10,000 patients, and he actually found that critical care interventions were incredibly common. Over half of these patients were intubated, 14% got dialysis, and 15% required some type of mechanical circulatory support device. He also showed, hopefully here you can see, a total of 30% of those patients died in hospital, 41% had died by 1 year, and that mortality kept continuing to change and sort of decline up to the 10-year mark. So it's not like you get to 1 year and you're A-okay. That risk of increased mortality follows you 5 years out and 10 years out. So understanding what's happening with these patients is so crucial to prevent further long-term sequelae. We talked about downstream earlier and upstream, and I think this is, again, understanding things at the upstream level. And then just to highlight two small sub-studies, we have a couple other papers that are ongoing now. Dr. Furtado led another study where he looked at mental health outcomes in survivors of AMI-associated cardiogenic shock. And he showed an increased rate of new mental health disorders, so about 109 per 1,000 patient years in the AMI-CS survivors, with increased risk being in patients that were female, patients who had a pre-existing mental health disorder, and the patients who were discharged to some type of institutional facility. And then I just want to highlight Dr. Parlow's work. He actually read this amazing work in terms of resource utilization and costs with AMI-associated cardiogenic shock, and showed us that the cost in hospital of one of these patients on average is about 23,000 at the 1 year mark, up to 37,000, and even for patients that died in hospitals, 17,000. So again, it's not to say, you know, we're not judge and jury in terms of who gets what intervention, but I think acknowledging that these are heavy resource utilizers at a person and financial level are important to understand, especially in the confines of a public healthcare system where understanding resource utilization is key. Lee also spent about 18 months piloting a CICU recovery clinics. This was launched in the summer of 2022. He really had an aim to provide a safety net for these high-risk patients, and he wanted to understand the patient experience in the CCU and also the functional status following hospitalizations. For the pilot, we actually kept it very, very broad. You can sort of see here. We had a total of 67 patients that were invited to follow-up, and almost a third of them actually died prior to follow-up. So again, I think to highlight the really high mortality that we see in these patients. And then we saw about 53% in clinic. Their median SF36 scores were very low, so 35 on 100, similarly with their 6-minute walk test of 206 meters. And the thing I found most fascinating about CIC Recovery Clinic was all the qualitative data that we got back. So the things that patients told us that they remembered about their hospitalization, that they understood, and more importantly, didn't understand about what happened to them in hospital, and what was most triggering in terms of being home. And I think, at least for me, even though the pilot was only 18 months, it completely changed how I approach these patients in the CCU. And I actually have a talk with all my patients about when they're getting ready to graduate out of the CCU, we actually review, this is what happened in the CCU, this is what you went through, these are next steps, and this is what to look for. And I intentionally use the word graduation because a lot of the feedback that we got from patients was, why was I all of a sudden okay for the ward? I was told I had this room in the ICU, I had one-to-one nursing, I was so sick, and then all of a sudden one day I'm just upstairs. And so I think helping patients understand this is part of your journey and you're graduating as part to go home, I have found helpful in informing my conversations with patients. And we've seen in the medical surgical ICU patient population reduce rehospitalization, improved quality of life, improved functional status with involvement and follow-up in post-ICU clinics. So why would that not be the same in cardiogenic shock? So I think just to sort of emphasize that. I'll skip over this. This is just a quick statement from in 2025 for the ACC-AHA on cardiogenic shock. I just want to highlight our trainees in the lab are looking at all the things circled in red. So we are really doing our best to add to the literature in cardiogenic shock. And then finally, I just want to highlight this is a team effort. I've tried to kind of mention a couple of people who are here. We have our amazing trainees, our phenomenal nursing team. Hanu Yen is sitting here as well. She was with our lab. And was irreplaceable in terms of Doremi too, our mentors and our colleagues, and then everyone in the unit. And I'll leave it at that.
Yeah. Oh, I guess that was fantastic. That was I have a lot of questions about inflammation. We could maybe connect afterwards.
Sure.
So I'll pass it around. Looks like Dr. Beelan's up first.
Yeah, fantastic,
Thank you.
Rebecca, really fantastic. I love the path on the patient journey. I love the emphasis on the trainees and their engagement in research. Congratulations on all the great work. I'm also fully support and proponent for randomized trials. I love how you highlighted the advantages of that. I wonder if you could comment on sometimes the trials get it wrong, hypothermia being an example. And the importance of the population that you're selecting and not selecting.
Yeah, no, for sure. I mean, just to speak to your point about hypothermia getting it wrong, I actually would flip it the other way and say this is why it's so important that we did do RCTs, right? Because we're going to study things as other parts of medical management move forward, and something that may have shown benefit 10 years ago, as the rest of our care has changed, may not show benefit and may actually show harm. And so that's why, I'm always a bit nervous about danger shock, because I think people have said NNT of 8, Impella for everyone. And so, it's important to replicate positive studies. There's a role for negative studies. And I think doing pragmatic trials, you want to have a real world patient population acknowledging that heterogeneity of treatment effect may not always be possible in a small study, right? But I think, there's one of the many things that COVID taught us was the benefit of HTE and kind of looking at this in RCT data, but you kind of have to do the trial in order to do it. So I agree the trials may not get it right, but man, isn't that half the fun of medicine is we kind of get it wrong, we fix ourselves, we rejig, and then try to get it right the next time. So I hear you, but I still think it's warranted. Yeah, 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 yep, yep. Yeah, and I think it's where, there's what we do clinically, there's understanding the literature, and then I think that's where the art of medicine is how do you bring that together and make decisions at the bedside? Yeah, I totally agree. Thank you so much. Yeah.
Any other questions? Dominate for a minute then. Okay, so I completely agree with you that the idea of sort of the earthquake pre-tsunami, where to look. I'm wondering, I just think of the patient population, they're so sick. What, when they're sort of, when they come to see you, how much can you learn about that? Sort of not only their own life history, but maybe, beyond, other risks, genetic risks, et cetera. It's also not, these trials are relatively small when it comes
Yep.
to overall, journey. So wondering your thoughts on that, because I fundamentally believe that that is what you're seeing
Yeah.
in it, the consequences of, rather than, it being fundamentally the cause in the moment.
Yeah, I mean, there's a lot of impending criticism, I think, on Doberman, but I think the one thing that Doberman did right was trying to siphon off a at-risk patient population. Because I think, our research in Doberman 2 is really focused on Sky C and D. And part of me is like, is the horse out of the gate at that point in time? Like, is the EF 10% and you're flogging it with inotrope, and like maybe you just got to give up and like put a MCS in or whatever. And so I think that I think maybe one of the better ways to approach that is to be really particular about stratifization or stratifying randomization and or how we're going to enroll sub cohorts. But I think the answer to that is actually phenotyping.
Right.
So I think you have to phenotype first,
Right.
know what you're dealing with, and then study therapeutic targets in very narrow windows. And this is where international collaboration becomes crucial.
Yeah.
Because if you're doing this over 5 or 10 sites in North America, it's going to take you 10 years. Look at
Yeah.
Danger Shock, right?
Yeah.
Danger Shock had to add in countries because they couldn't recruit, right? Like I forget the original name of Danger Shock, but sure was because of Germany, right? Like, do you remember the original name of Danger was in Denmark? Yeah. And so I think there's a lot to be said, at 3CT, we talk about this a lot of like international nested clinical trials, where that way you can recruit a 2,000 patient study in 48 months, as opposed to recruiting a 300 patient study in 6 years. So I think like phenotyping, subphenotyping, siphoning off like the pre-shocks, because I think they'll speak more to the upstream intervention. And then I think more international collaboration for more rapid patient recruitment. And I think deferred consent is a bit controversial. And so we have a very different approach in North America than I think our colleagues in Europe. But I think that there's something there too. I don't know if that answers the question.
Yeah, absolutely.
My thoughts.
Yeah, there's lots to
Unpack.
Yeah. Questions? Any other questions? No? That was fantastic. Thank you so much. Thank you, everyone.